benign and malignant tumors of oral cavity. Actually, a tumor is nothing but a swelling seen anywhere. It does not represent any neoplastic process. Okay, neoplasia is the term given for any abnormal or excessive growth of the tissue, the growth of which exceeds that of the surrounding normal tissue. So neoplasia is an abnormal growth of the tissue which is uncoordinated with the normal growth. Okay, we'll be seeing the benign tumors of oral cavity and the malignant tumors of oral cavity. We'll see the benign epithelial tumors, that is the benign tumors which are arising from the epithelial tissue origin, and the benign tumors which are arising from the connective tissue origin. Similarly, we'll see the malignant tumors arising from the epithelial tissue origin, the connective tissue origin, and even the tumors which are of a disputed origin. And we'll be seeing the tumors of salivary glands separately, and we'll see the precancerous lesions separately. So between benign and malignant tumors, these precancerous lesions and conditions, they show a transition from the benign forms to the malignant forms. Okay, so benign tumors are just manifested in oral cavities as swellings. They just appear as swellings. They may be asymptomatic or symptomatic depending on their growth. Okay, so the first benign tumor of oral cavity, which is of epithelial tissue origin, is nothing but a squamous papilloma. Squamous papilloma, as the name indicates, it's a papillomatous growth or a papillary outgrowth swelling of the tissue. It is basically a fourth most common oral mucosal mass and is found in 4 in every 1,000 individuals. Okay, so it is very less uncommon lesion, we can say. Okay, it is very less frequently seen. So the clinical appearance of papilloma. So if you can see the clinical picture there, we'll study all the tumors just comparing it with their clinical pictures. Okay, we'll be studying the appearance of the lesion, how it appears clinically, how to diagnose clinically. We'll be seeing the microscopic pictures of the lesion, radiographic pictures, if any, if present, if there is any osteoid deposition, only then we can see it radiographically, right? So radiographic pictures, if any, histopathologic pictures, and what are the treatments options available for that particular tumor. Okay, for squamous papilloma, if you can see the clinical picture there, it just appears as an exophytic growth or a papillary growth or a proliferation of the soft tissue, which is just giving the lesion a roughened appearance or a cauliflower-like appearance. Okay, soft tissue proliferation, which is papillary in nature or cauliflower-like in nature. And this tumor mass, it may be well circumscribed, so it is just fixed within the tissue and it may be attached to the normal tissue by a stalk. That's why it's called as a pedunculated tumor mass. Sometimes, occasionally, this peduncle may be absent, pedicle may be absent, making it a sessile mass. Okay, the squamous papilloma, most commonly it is manifested as a pedunculated tumor mass, and it is painless. It is painless. Yeah, squamous papilloma is seen in the skin commonly, and it also occurs in the oral cavity. So here this pedunculated appearance is seen in the skin. Okay, it is painless. It is just a soft tissue outgrowth. It is not related to any pain. Sometimes there is a color change, that from normal it appears to be little bit pinkish in color, and the squamous papilloma, it occurs at any age, does not show any predilection for occurrence in any gender, and the most common sites in oral cavity where we see this squamous papilloma are the tongue, lips, buccal mucosa, gingiva and palate. And the few of the authors, they have reported a lot of similarities between the squamous papilloma and the verruca vulgaris. Verruca vulgaris is the nothing but a common wart which we see, wart like a lesion which we see, the common wart. It is analogous to oral papilloma. It is having similar clinical pictures of a papillary verrucous projections, but the difference between squamous papilloma and verruca vulgaris is that is in the etiology. Verruca vulgaris is associated with the human papilloma virus. Okay, human papilloma virus type 10 and 14 are more commonly implicated with the appearance of verruca vulgaris. Whereas when we see the squamous papilloma, the papilloma virus as such is not seen. The types are different. It is not a common etiology here. Okay, the common wart, it presents as a pointed or vericiform surface projections, giving a similar appearance of oral papilloma, and it is contagious. Whereas the oral squamous papilloma or the squamous papilloma seen on skin is not contagious. So, because of the similarity in clinical appearance of verruca vulgaris, it is just considered here to just differentiate between the two lesions, the oral squamous papilloma and the verruca wart or the verruca vulgaris. Okay, if you can see the clinical picture there, the tonsillar pillar, it shows, it's just marked with a circle there, it is showing the appearance of a wart or a mole. Okay, that's the appearance of a wart on the oral mucous membrane, oral cavity. Okay, the fascial pillar is showing the wart. Now, if you see the microscopic picture of the oral squamous papilloma, okay, it is basically arising as a proliferative growth, right? So the apparent hyperplasia of the epithelium is present. Okay, here you can see in the histologic picture, the appearance is one of hyperkeratosis or hyperplasia of the epithelium with long thin finger-like projections of the epithelium, squamous epithelium. It just projects into the surrounding mucosa. Long thin papillary projections are seen. Proliferation of the epithelium is seen, and the stratified squamous epithelium is seen, which is containing a central connective tissue core. And as I said, hyperkeratosis and hyperplasia of epithelium is seen. Most commonly, we have seen that there are different layers of the cell. The spinous layer of cell, they show proliferation, they show excessive elongation. And virus altered epithelial cells, that is human papilloma virus altered epithelial cells called the coilocytes, are sometimes seen, not always encountered in oral squamous papilloma lesions. The coilocytes are nothing but they show some enlarged nucleoli and some perivascular clumping of nuclei is seen. So the enlarged nucleoli is the characteristic feature of this coilocyte. So that's the histologic picture of oral squamous papilloma. Okay, central connective tissue core is present along with a thickened epithelium, hyperplasia of epithelium. The epithelium just extends into the adjacent mucosa in the form of long finger-like projections, as we have seen in the histologic picture. Treatment for oral squamous papilloma is nothing but excision of the tumor. Recurrence is very rare, and since it is not a contagious, there are no chances of spreading to the other parts of the body. Whereas verruca vulgaris or wart, if you more commonly they are seen in the regions of neck or and because of auto inoculation, the human papilloma virus or verruca vulgaris, it is a contagious lesion, right? Because of auto inoculation, it just keeps on spreading to other body parts. Suppose it is occurring in regions of trauma or in regions where it is constantly being traumatized, then it has to be excised surgically, verruca vulgaris. If it is not causing any problem, you can just leave the lesion like that, verruca vulgaris. Only because of auto inoculation you may have problem, and verruca vulgaris or wart, it is not seen in oral cavity anywhere. Only because of auto inoculation only you can see the clinical manifestation or appearance of wart in oral cavity, as we have seen in the clinical picture there. So that's about the squamous papilloma. Now we'll see the other benign tumor, that is the keratoacanthoma. Keratoacanthoma, it's also known as a self-healing carcinoma or a molluscum sebaceum or a verrucoma. The characteristic feature of keratoacanthoma is that the histologic picture and the clinical picture both give an indication that it may be a squamous cell carcinoma or it may be an invasive variant of a squamous cell carcinoma, but that is not the thing. The keratoacanthoma is a relatively benign neoplasm, it is uncommon neoplasm. And the etiology also gives an indication that it may be squamous cell carcinoma because the sunlight is the etiologic factor for development of this keratoacanthoma, and this is nothing but a benign tumor occurring in the pilosebaceous glands. Okay, trauma, human papilloma virus, genetic and immunologic factors, and immunocompromised status of the individual aggravate the condition, or they may be the causative factors for occurrence of this keratoacanthoma in the pilosebaceous glands. Keratoacanthoma, it is seen in all age groups. It occurs twice frequently in the women as compared twice frequently in men as compared with the women. Okay, so male predilection is say there. Then the keratoacanthoma, the lesions are most commonly seen on the face, neck, and the dorsum of the upper extremities most commonly. So the sun exposed areas are the middle third of the face. So they show characteristic appearance of this keratoacanthoma. So how is the clinical appearance of keratoacanthoma? If you can see the clinical picture there, they begin as a papillary lesion, solitary means they'll be seen in a single form. Okay, single solitary lesion may be seen, and it will be firm, round, reddish papules. Initially they develop as papules which are slightly raised from the surface, then they progress to become a nodule with a central depression. Even in the clinical picture there you can see there is appearance of a nodule with a central depression, giving the appearance of an umbilicated or a crateriform nodule with a central depressed core or plug. Even the histologic picture is characteristic of this Keratoacanthoma. It is showing the similar features of keratin plugging or central depression. So along with the appearance of the nodule, you can see that the lesion is painful. The patient complains of pain, and regional lymphadenopathy is present, denoting that the features of metastasis may be present, but it is not such a case. Okay, so the clinical appearance is one of a nodule and which is showing a central depression or core. So now when you see the microscopic picture of the lesion, it is showing a presence of a hyperplastic epithelium again, and this hyperplastic epithelium just seems to grow into the underlying connective tissue. The surface is covered by a thick layer of parakeratin, and why it is Keratoacanthoma is being compared to squamous cell carcinoma is that the epithelial islands of cell, whatever are present, the squamous epithelial island cells, they appear to be deeply invading into the connective tissue, and few mitotic changes or cellular atypia, minimal cellular atypia is present. For that reason it has been compared to squamous cell carcinoma. But once you see the clinical pictures and correlate it with the histologic pictures, it has been shown that this is a non-invasive, non-malignant tumor. It is just a benign tumor of oral cavity, and treatment for this is nothing but surgical excision of the tumor without incidences of recurrence. Okay, sun exposed areas, that may be the irritating factor, or sometimes even the chromosomal abnormalities may be the irritating factor for development of this Keratoacanthoma in the pilosebaceous glands. Okay, now other commonest benign tumor of epithelial tissue origin is oral nevi, also known as oral melanocytic nevus. The mole, it commonly occurs on the skin. It is also seen in oral cavity, so that's why the name oral melanocytic nevus is given. Nevus cells, basically they are derived from neural crest cells, and their origin is supposed to be the neural crest cells, and they may show deposition of melanocytes, and the melanocytes show the deposition of melanin granules. So the oral melanocytic nevus will be dealing with both the lesion, the nevus cells, how they appear in the skin lesions and how they appear in the oral cavity. Okay, based on their histologic locations, the nevus, the oral melanocytic nevi, this is about the normal nevus. Okay, the normal nevus, it is just divided into the junctional nevus, the compound nevus, and the intradermal nevus. How, on what basis? On histologic basis. How in the junctional nevus, the nevus cells, which are the causative of causing this mole, they are just limited to the basal layer of the epithelium, that is the lowermost layer of the epithelium. Whereas in the compound cells, nevus cells are seen both in the epidermis and dermis, whereas in the intradermal nevus cell, nests of epithelium are seen entirely in the dermis region. And the intradermal nevus, when it occurs in the oral cavity, it is called as a intramucosal nevus, and it is seen only in about 5% of cases. Oral melanocytic nevus is seen of all the generalized nevus symptoms when we see in skin. Okay, only 5% incidence of oral melanocytic nevus is reported. So based on their location or the time of appearance, the nevi are divided into the congenital nevi and the acquired nevi. These are nothing but nevi which are occurring on skin. Okay, first we'll be dealing with the nevi which are appearing on skin. The congenital nevi, there are two types, like the small nevi and the garment nevi. The term small nevi is used when the lesion or the nevus or the mole, it is just greater than 1 centimeter and less than 3 centimeter. Whereas the term garment nevi is used when the lesion or the nevus, it is greater than 10 centimeter in diameter. So clinical appearance of the lesion, as you can see there is a nevus or a mole occurring on the nose. It may range from a pale, flat, pale tan macule, that is just not raised from the surface. It is just a flat pain lesion seen. Sometimes it may be just elevated or a verrucous, or sometimes hair may be seen protruding from the mole. So that is the appearance of a congenital nevi. Congenital nevi are present at the time of birth, and they may be detected at a later stage in the life. And acquired nevi are extremely common. They appear, they are not present at birth. Acquired nevi are one which arise at about 8 months of life after birth, and the prominence appears to increase with increasing age. And there have been cases reported of transformation of this congenital nevi into malignant melanomas, but it is very rare. So because of this significant risk associated, children are generally screened for the appearance of this nevi. Okay, so that's the appearance of acquired nevi there. Flat, pale, tan macular lesion is seen. Or the elevated one with hairs protruding from surface. Those two are the clinical appearances. So now we'll see the intradermal nevus. When it is appearing in the dermis region, the nevus cells are specifically concentrated only in the dermis region. The lesion may again be a smooth, flat lesion called the macular lesion, or it may be elevated. Both the forms of nodular lesion or flat, pale, tan macules are seen. And pigmentation is the characteristic feature because melanocytes are deposited along with the nevus cells. Melanocytes show deposition of or increased production of melanin granules, giving the characteristic brown appearance or brown pigmentation to the lesion. And strands of hair appear to be growing from the surface. And there is another common nevus which is encountered in children, that is nothing but a spindle cell nevus or epithelioid cell nevus, or a splits nevus as it is called. It is chiefly seen in children in the region, in the back and the upper extremities, face, neck. These are more commonly in the buttocks. These are the common sites where you can see the Spitz nevus. And this lesion, Spitz nevus, clinically it is a benign lesion, but histologically it appears to be malignant, and it shows the features of malignant melanoma. Actually, the Spitz nevus, you can see the appearance of Spitz nevus there. Again, it is just a flat, pale macule, and there is slight change in the color to red or brown in color. The blue nevus is actually an intramucosal nevus. As I told you, nevus cells are just concentrated in the mucosa. The submucosa region is more commonly shows the appearance of this blue nevus. Blue nevus actually it represents a true mesodermal structure because it is composed of dermal melanocytes, and chiefly the blue nevus it is seen on the buttocks, on the dorsum of feet, hand, face, and even the oral cavity. The blue nevus it is present at the time of birth, and it remains unchanged throughout the life. So it is congenital type of nevus, the blue nevus, and the lesions are smooth, pale, tan, macular lesions which show hairs growing from its surface, and the characteristic appearances of colors, because this blue nevus it shows the presence of true mesodermal dermal melanocytes. It shows the characteristic color from blue brown to bluish black. Okay, so this is the characteristic appearance of blue nevus. You can see the H&E staining, it is showing the appearance of the brownish color mesodermal melanocytes present, and the nevus cells are concentrated in between the melanocytes. The connective tissue proliferation is seen there. Okay, now we'll see the oral melanocytic nevus. The oral melanocytic nevus, or the occurrence of mole, it is more commonly seen on the hard palate region. Okay, it just appears as a macular lesion there. Buccal mucosa and gingiva are less frequently affected. The appearance of mole itself is generally asymptomatic. It is usually detected on examination. Patient does not have any problem or any symptoms relating to this lesion. Okay, pigmentation occurs in the region of wherever the nevus cells are deposited. Mesodermal melanocytes also tend to be accumulated along with them, and the pigmentation is characteristic of appearance of mole. So the nevi cells, how they are arranged, they are just well circumscribed nevi which are round, oval in the hard palatal region. They are round, oval, and they may be slightly raised from the surface. As seen on the skin, macular lesion to nodular lesion change. Even in the oral cavity, the lesion may appear to be a flat one, or it may be a raised from the surface one. When you see the characteristic microscopic picture of nevus cells, the nevus cells in histological slides, microscopic slides, they just appear as large round ovoid spindle shaped epithelial cells which lack cytoplasm, which are showing a clear cytoplasm or a pale cytoplasm, and the nucleus is relatively vesicular. It appears to be hypochromatic. Along with the nevus cells, obviously melanocytes are deposited because melanocytes are also derived from the neural crest cells. Okay, so the melanocytes show deposition of melanin granules in the cytoplasm. So the intradermal nevus, whenever you see the appearance of intradermal nevus, we know that intradermal nevus denotes deposition of nevus cells in the dermis region. So nevus cells are specifically concentrated within the connective tissue only. Whereas the junctional nevus, when we see, it is showing deposition of nevus cells both in the epidermis and dermis, right? So the nevus cells contact, nevus cells, they are seen both in the connective tissue as well as in the epithelium, and there seems to be a blending between the epithelium and connective tissue. Okay, the nevus cells, they just tend to drop from the epithelium into the connective tissue. So this dropping off effect is also known as Aptrop-Fung effect. Okay, Aptrop-Fung effect or dropping off effect. That is nothing but the nevus cells are concentrated both in the epithelium and the connective tissue, that is in the dermis and the epidermis, and the epithelial nevus cells, the islands of nevus cells, they just tend to drop off into the connective tissue. Okay, the compound nevus is nothing but a nevus which shows the features of both the junctional nevus and the intradermal nevus. The epithelioid nevus, as we have discussed, it is a specific form or a special form of nevus which is occurring only in the children. So this epithelioid cell nevus, as the name indicates, spindle cell nevus. So spindle cells are seen along with epithelioid cells and mononuclear phagocytes histologically. And the common blue nevus, that is nothing but blue nevus, true collection of mesodermal dermal melanocytes. It is a true mesodermal structure which is composed of melanocytes. So increased melanocytosis is seen, increased deposition of pigment is seen. So histologically also you can just see elongated melanocytes are present. These melanocytes lack their usual dendritic processes which are seen. Okay, and they just seem to blend off with the nevus cells. Whereas the cellular blue nevus is seen. In cellular blue nevus, the nevus cells appears as a large round spindle cell with the pale vacuolated cytoplasm, the characteristic feature of nevus cells. So here you can see the compound nevus. It is showing the nevus cells which are present in both in the epithelium, and it is just extending into the connective tissue also. Compound nevus is nothing but a mixture of junctional and the intradermal nevus. In intradermal, nevus cells are concentrated in the dermis, whereas in junctional it is showing both in the dermis and epidermis. So here the features of nevus cells are seen both in the dermis and epidermis, that is in the epithelium and connective tissue. So the characteristic Aptrop-Fung effect or dropping off effect is seen here in compound nevus. And whereas in Spitz nevus, as you can see, the spindle shaped epithelial cells are seen. In the epithelium, if you concentrate, there are some islands of epithelium cells seen. Those are nothing but spindle shaped cells or epithelioid cells. Along with that, characteristic multinucleated gain cells may be seen here and there. This is the cellular blue nevus. As you can see, cellular blue nevus, it is just showing a large round spindle cell with a pale vacuolated cytoplasm. This is the appearance of a single cell. And this is nothing but epithelioid blue cell. That is the spindle shaped cell, spindle cell or the Spitz nevus. It is showing the depositions of islands of spindle cells and epithelioid cells. So that is a characteristic of one epithelioid along with the nevus cells which are appearing vesicular. So that's about the benign tumors of epithelial tissue origin. For oral melanocytic macule or mole, it is just commonly asymptomatic, right? There are no incidences of any trauma or any problem being caused to the individual. So they are just detected on routine examination, and they are just no treatment is required for the nevus cells. Benign tumors of connective tissue origin. Okay. So first is the oral fibroma. As we can see, fibromas are the commonest lesions seen in oral cavity. There is other common notion that fibromas just represent the reactive fibrous hyperplasia of the tissues. Hyperplasia is nothing but increase in size of the epithelium or thickness of epithelium is increased owing to some form of irritation. So fibrous hyperplasia and fibroma are both one lesions. It was proposed like that, but the appearances seem to be same. Only histologic differentiation were seen between the two. Okay, so oral fibroma, it's also known as irritation fibroma. The other name itself gives an indication that the etiology for this neoplasm, this benign tumor fibroma, is nothing but irritation or trauma to that area. It has been compared with focal fibrous hyperplasia. Fibroma is also known as a focal fibrous hyperplasia because it ultimately represents hyperplasia of that particular tissue. So histologic examination gives an indication of appearance of fibroblasts in that region owing to the designation, the term fibroma. Okay, so the etiology is nothing but trauma or local irritation. Fibromas can be seen anywhere in the oral cavity. buccal mucosa along the line of occlusion, because this is the site where the cuspal occlusion, there is occlusion of both the maxillary and mandibular teeth. So sometimes any sharp cusp present, they may lead to a plane of occlusion along the buccal mucosa. It is normally seen in oral cavity as just a line. Along this region, if any sharp cusps are present and there is a trauma repeatedly to that particular plane of occlusion, it leads to development of this fibroma at that particular site. And gingiva, tongue, lips, any palate, any site which is constantly being traumatized or irritated leads to development of this fibrous hyperplasia or oral fibroma. And the occurrence of fibroma is seen at any age. There is no particular age like that. It may be seen from about 10 years to about 80 years of age, about 67 years, any age. And the females are seen to be more commonly affected than males. And clinical appearance of fibroma is one of a nodular lesion. So the color of the fibroma is same as that of normal color of the oral mucosa. It just appears to be raised from the surface. Nodular lesion is seen, which is raised from the surface, similar color to the normal mucosa, and the surface of the lesion is very smooth. Okay, as you can see in the clinical picture there, the buccal mucosa, it's showing a fibroma that's traumatic in nature, seen along the plane of occlusion, and the fibroma, the clinical appearance is just of an elevated nodule. Okay, it is a well-defined lesion. It is a very slow growing lesion. Okay, and nodular lesion, and there is no color change of that particular lesion. Okay, here there is appearance of fibroma on the upper eyelid. Okay, it's just the same color of normal mucosa or the normal skin. As we can see, this is fibroma occurring in the skin. So it's of the same color. It's just like a nodular, like a thing. It is just soft to palpate. When you see the microscopic picture of such a fibromatous lesion, it is excised and sent for histopathologic examination. You see that bundles of interlacing collagen fibers may be seen. The stratified squamous epithelium is present. It is showing apparent flattening of the rete ridges. There is thinning of the rete ridges, and the collagen fibers are present in the connective tissue excessively, and abundant fibroblasts are present that denote that the fibrous fibroma, characteristic of fibroma is the appearance of bundles of collagen fibers and fibroblast. Sometimes areas of diffuse or focal calcification or osteoid deposition may be seen, and sarcomatous changes may be seen. That's a different thing. The malignant form is known as fibrosarcoma. So it is a different appearance clinically and different appearance histologically. But here, when you see the benign variety of fibroma, just the epithelium is there with the apparent thinning of rete ridges, and in the connective tissue, just the collagen fiber bundles and fibroblasts are present. Okay, treatment is nothing but conservative surgical excision of that lesion. Recurrence is very rare. If that particular area or the etiology is not removed, the trauma is continuing, you have not removed the trauma, then that lesion may just recur. The lesion may recur. And the underlying etiology or trauma is identified and just removed, the traumatic factor is removed, after excision there is no chance of recurrence. Okay, Lipoma, as the name indicates, deposition of adipose tissues. So the lipoma is nothing but a tumor of adipocytes. It's a benign neoplasm. It is a very slow growing neoplasm. It is composed of mature flat cells. This deposition of adipose tissue may occur at anywhere along the body surfaces. Wherever commonly you see the adipose tissue, sometimes there is just abundance of the adipose tissue in that particular lesion. So you can suspect a lipoma of that particular lesion. And the lipoma cells, they have the characteristic that suppose the individual is on starvation, the fat which is present in the normal body fat, it helps it for counting the starvation by the individual. But this lipoma cells, they do not undergo any transformation, or they do not give out any energy to the body in cases of starvation. Okay, and the fatty acid precursors are just deposited in the lipoma or the neoplasm, just giving rise to or aggravating the lipomatous lesion. Lipoma is also seen in the oral cavity. It is a relatively rare lesion. When you are seeing in the oral cavity, it is relatively rare in origin, and it may be of two forms: the superficial lipoma or a deeper lipoma. So the clinical appearance of those is different. Lipoma is basically seen in adults about the middle-aged individual, there is no gender predilection. The size of the lesion, the lipomatous lesion, it is just about 3 centimeters. And when it occurring in the oral cavity, it is seen along the tongue, the floor of the mouth, the buccal mucosa more commonly. Okay, and gingiva also shows the appearance. So you can see the clinical picture there. The yellowish color, yellowish white or yellowish pink lesion, that is nothing but a lipoma. Lipoma usually it appears yellowish in color. So there are two forms, as I told you, superficial and deep lipoma. The superficial lipoma, as you can see in the clinical picture, the lipoma is appearing on the skin, the back, skin of the back. It is appearing as a overgrowth of the tissue, of that particular tissue. It is appearing as a single or lobulated lesion which may have a base. It may be attached to the underlying tissue. More commonly, the lipomas are just movable beneath the mucosa. Okay, lipomas are freely movable. The epithelium of the whatever is surrounding the lipoma, the epithelium, it is very thin, and the lipoma has a content of yellowish fluid which is relatively soft to palpation. So whenever the lipomas are superficial, you can just make out that it is like a soft outgrowth of the lesion. Soft mass is present, which is nodular or sessile. It may be seen individually, or it is just freely movable. And when it is occurring in the diffuse form, lipoma, it is situated little bit deeper, and it is little bit wider in origin. And when you just palpate the lesion, you feel that the lipoma is so soft in nature, you feel that there is an underlying cyst, fluid like a thing is there. So it gives a misdiagnosis of a cyst. Okay, because of its diffuse nature and because of its softness, when you palpate, you feel that it may be a cyst. Okay, these are nothing but excised lipomas. And mostly the fluid content or whatever, when you excise the lipoma, when you see the nature of the lipoma, it is just yellowish in color and lobular in nature. Okay, when you see the microscopic picture, specifically the specimen, it shows the predominant mixture of adipocytes is present along with collagenous tissue, and the stroma, it is seemed to show excessive deposition of the fat cells. The fat cells, these lesional fat cells, that is the tumor, the fat cells, the adipocytes which are causing lipoma tumor, they are different from the normal fat cells because in the metabolic process only. Clinically, histopathologically, they may be just same, that is the single large cell with a vacuolated cytoplasm and a small nuclei placed at one corner. That is the characteristic appearance of a adipocyte, but it may be different metabolically. As I have told you, when cases of starvation are seen, the fat cells or the adipocytes of normal body fat are activated, but these are not activated to give energy. Okay, and there are various forms of lipoma. That is, if excessive fibrous deposition is seen along with the adipocyte deposition, it is known as fibrolipoma. If in fibromatous lesion or the benign tumor or fibroma, if excessive number of vascular channels are seen, some capillaries are seen, it is known as angiofibrolipoma, and if uniform spindle-shaped cells, that is spindle-shaped cells or epithelioid cells are seen interspersed along with the adipocytes, they give the term myxoid lipoma. It is myxoid lipoma, denoting some different form of tissue is occurring in the lipomatous lesion. So that's the histologic picture of a lipoma. So the treatment for lipoma is nothing but excision of that tumor, and it is very benign. It is rarely it recurs. Okay. Lipomas of oral cavity are just excised, and they do not show any malignant transformation or any recurrence. Oral hemangiomas. Oral hemangiomas are basically the benign tumors of connective tissue origin. Oral hemangiomas and vascular malformations both denote some changes in the vascular channels, that is the arteries, veins, capillaries. Because of that, they show characteristic appearance of this malformations, that is the tumors in the skin in the oral cavity. Okay, we'll be studying the hemangiomas of the oral cavity. Okay, the hemangiomas are basically, initially they were author placed that both the hemangiomas and vascular malformations denote the same benign tumorous lesions, but there is a difference in pathogenesis of this hemangioma. How do this hemangiomas arise? Basically, what happens is the primitive mesenchyme, which is supplied during the embryonic development. It is supplied by some underformed vascular channels which are not differentiated into arteries, capillaries, veins, etc. So that is the first stage or the early stage. In the later stage, in the retiform development stage as it is called, there is appearance of few interconnecting channels like arteries and capillaries. Okay. In the later development stage, complete plexus of blood vessels is completely formed here. So if the defect is occurring, if the defect of blood vessels, it's occurring around the early developmental stage where there is no formation of any complex of blood vessels, no arteries, no capillaries are seen, just a undifferentiated blood vessel, undifferentiated complex of vessels is seen. That stage, if any abnormality or tumor occurs, that is known as a hemangioma. Vascular malformations are malformations which are seen after the arteries, veins, capillaries develop in the later stage, in the third stage, that is after the retiform development. If any tumor arises, any interconnection happens between the artery, capillaries and veins or lymph vessels, it gives rise to the vascular malformations. Okay, so that's the difference in the etiology or the level of development of this hemangiomas and vascular malformations. Oral hemangiomas, they basically manifest within the first month of life and they exhibit a rapid proliferative growth. Basically, they are not present at birth. Hemangiomas are not present at birth. They are seen after about first month of life, and premature born babies, they show characteristic appearances of this hemangiomas, oral hemangiomas, because they may show a delay in development of vascular channels or any anastomosis occurring between the arteries, capillaries, veins. Any disturbance occurring in formation may lead to the occurrence of this hemangiomas in premature babies especially. So the clinical appearance of hemangiomas is characteristically observed at second decade of life. Though they may begin after first month of life, they are only observed in the second decade, that is about 10 to 20 years of age. It is more commonly seen in females. So you can see that is the excised hemangiomatous lesion. The clinical appearance of lesion you can just make out, we'll study detailedly. Most commonly, if the hemangiomas they have an effect on the bones, surrounding bones, whatever involved. That is the mandible, maxilla and facial bones. Maxilla more commonly involving the sinus is affected. And whereas vascular malformations are present at birth and they continue to just grow with the child. Hemangiomas are not present at birth, they arise after 1 month of life and they just remain same in size, or they may show little bit increase in the size. But vascular malformations, because they arise in the later stage of development and there is a definite arteries, capillaries, veins are present and there is arteriovenous aneurysm, or there is some defect in interconnecting lymph vessels. The arteries, veins, they just become interconnected with other lymphatic vessels and that gives rise to the malformations, right? So they are seen at the time of birth and they just continue to grow or they cause problems as the child increases. The clinical appearance of hemangioma is one of a flat or raised lesion of oral mucosa. Usually it is deep red or bluish red in color, and there are different types of hemangiomas based on the type of vessel it is affecting. Okay, capillary hemangioma, cavernous hemangioma, or hemorrhagic, hereditary hemorrhagic telangiectasia, or a racemose type of hemangioma. So based on the type of hemangioma, they were divided into different types. Okay. So the capillary hemangiomas are one which appear as raised or lesions of oral mucosa. So whenever they are compressed and released, they readily fill up the lesion. So whenever they are compressed, they are just very compressible. So whenever 2 fingers are applied on the lesion and just pressure is applied, it just gets, the lesion just gets depressed. So that's showing the feature of compressibility. And whenever the fingers are released, the lesion just gets filled up again. So that's the characteristic feature of compressibility, is the characteristic feature of the capillary hemangioma. Okay. Even the blood filled spaces, that is the cavernous hemangioma, also show a similar feature. And more commonly, these capillary hemangiomas are seen on the lips, in oral cavity specifically. Okay. Lips and even the tongue, buccal mucosa and palate also show the appearance of this capillary hemangioma or the cavernous hemangioma. Sometimes what happens is some tiny vascular malformations, as we have told, both the hemangiomas and vascular malformations are studied together because of their characteristic etiopathogenesis. Okay, vascular malformations are different in only aspect that they are present from birth and they continue to increase in size. If you can see the clinical picture there, that is of a vascular malformation seen in the child, maybe a arteriovenous aneurysm or a fistula that is just growing with the child, and sometimes small vascular malformations are seen on the lip. Those are nothing but the microcherry or the glomerulus. So this is the histologic picture of a cavernous hemangioma. It is showing the blood-filled sinusoidal spaces which are just lined by endothelial cells. Okay, and that is the appearance of a capillary hemangioma on the scalp of a child. So radiographically, you can detect the vascular malformations or this hemangiomas by angiography. Angiography is the study of blood vessels, so it gives you a correct picture of the vascular malformations, or the correct diagnosis of the vascular malformations may be made based on angiography. And sometimes when the hemangioma is occurring within the maxilla or the mandible, the central hemangioma of bone as it is called, it appears as a radiolucent lesion, and it shows a characteristic honeycomb pattern. So clinical diagnosis of central hemangioma of bone cannot be done. The radiological diagnosis is also misleading. Only when you surgically encounter this radiolucent lesion and you see that excessive blood will be welling out from the tissue, and the blood loss will be very, very severe, and when such a severe blood loss is occurring, that gives the indication that it is a central hemangioma. There is a hemangioma occurring in the mandible. It was seen. Okay, and when you see the microscopic picture of hemangioma occurring anywhere in the oral cavity, lips or anywhere, you see that small capillaries are present. This is basically hemangioma is a defect in the blood vessels, that is the capillaries, arteries or vein. So many small capillaries are seen which are just lined by a single layer of endothelial cells, and these endothelial cells show proliferation. Okay, that is a characteristic feature of a capillary hemangioma. Whenever you see cavernous hemangioma, large dilated blood-filled sinuses will be seen, which are just lined by a thin wall, and the thin walls are lined by show endothelial cells, presence of endothelial cells. Treatment for capillary and cavernous hemangioma is carried out only when they are of such a indication that they are causing cosmetic problem because of the characteristic color and because of the raised lesion. If they are causing any problem, more commonly in the lip, if it is seen the glomerulus or microchilus, whatever the vascular malformation is seen, if it is causing a cosmetic problem, it is just surgically excised, and sometimes radiation therapy is also given in cases of central hemangioma of bone. So here the characteristic picture of a capillary hemangioma. Capillary hemangioma is just showing the proliferation around the capillaries. Small capillaries are seen which are lined by endothelial cells. Endothelial cell proliferation is seen. Whereas the cavernous hemangioma, it is showing a blood-filled sinusoidal space. The pinkish color blood is filled in the sinusoidal space. And hereditary hemorrhagic telangiectasia, as I told you, hereditary hemorrhagic telangiectasia is also a form of hemangioma occurring in the oral cavity. It is also known by other name as a Rendu-Osler-Weber syndrome. It is basically an autosomal dominantly inherited disorder. It is characterized by a triad, that is 3 symptoms characteristically occur in this hereditary hemorrhagic telangiectasia. That is the occurrence of telangiectasia, that is the appearance of raised or lesions on the skin, superficial or deep lesions on the skin which may be flat or raised, which is showing the characteristic color. Along with that, recurrent epistasis or bleeding from the nose, and a positive family history denoting the autosomal dominancy. Okay, etiology for the hereditary hemorrhagic telangiectasia is nothing but inherited defect. As we have already studied the etiopathogenesis of hemangioma, it is basically there is a defect during the embryonic development. There is a defect in the formation of capillaries and arteries and veins, and that is leading to the defect in the primarily in the capillaries, the defect in the endothelial cells, that gives rise to this hereditary hemorrhagic telangiectasia. So clinically, the appearance of telangiectasia are nothing but a spider-like telangiectasia is seen. That is nothing but a flat or raised lesion which is increased with increased pigmentation. Okay, they are present at birth, or they may develop shortly after birth. There is 1 month or 8 months after birth, and they appear to increase in number as the child advances in age. And more commonly, the spider-like telangiectasia are seen on the face, the neck, or the chest. So here epistasis or bleeding from nose, recurrent bleeding from nose occurs for the child. The child advances, and recurrent episodes of bleeding has to be along with that occurrence of the spider-like telangiectasia anywhere on the body. This too should make you suspect this hereditary hemorrhagic telangiectasia, or a defect in blood vessels has to be suspected. And this kind of telangiectasias also occur on the skin and oral mucous membranes also. In the oral mucous membrane, as you can see, the occurrence of few flat pale lesions on the lips, lower lips. So they are just flat pale lesions. They may be macular lesions, just they are very flat and are not appearing to be raised from the surface here. So as I told you, there is an inherited defect in the capillaries here that is giving rise to this defect. So the microscopic appearance is actually of a hemorrhagic lesion. So this appearance of tiny hemorrhages, it is because of a primary intrinsic defect of the endothelial cell. There is a defect in the endothelial cells which line the capillary blood vessels, leading to the detachment of endothelial cells from the blood vessels. That leads to these hemorrhages, and sometimes there is a defect in the surrounding blood tissue which is supporting the blood vessels, that is blood-filled sinusoidal spaces. Okay, treatment for hemangioma is nothing but excision if they are of such a size that they are causing any problem. Other than that, cautery is carried out, electrocautery is carried out. Other than that, there is no, sometimes there is spontaneous regression of the hemangiomatous lesion as the child advances in age, as regression may also be seen sometimes. Okay, now we'll see the other common benign tumor of connective tissue origin, that is a lymphangioma. As the name itself suggests that this tumor is some abnormality in the lymph vessels is seen in this tumor. Okay, it's given, and the name itself is giving an indication. So the lymphangioma is basically a benign hamartomatous hyperplasia of the lymphatic vessels. The clinical appearance of lymphangioma most commonly is that seen in the neck as cystic hygroma. That is, the lateral area of neck shows the occurrence of a nodular swelling or a cystic swelling, which just tends to be very large. As you can see, the child is affected by cystic hygroma or the lymphangiomatous swelling. It is showing the benign proliferation of lymph vessels there. So the lymphangioma may be present at birth. More commonly, it is seen in the head and neck region, and more commonly in the lateral neck. The lesion typically appears as a large cystic spaces, hence the name cystic hygroma is given. Intraorally, lymphangioma is seen on the tongue, palate, buccal mucosa and gingiva. Lymphangiomas also appear, they may be superficially situated or deeply situated. The superficial lesions appear as papillary lesions, which are just papillar lesions, which are just seeming to protrude from the surface, and they tend to be of a redder in color, slightly red in color. Whereas the deeper lesions, which are situated little bit deeper, they appear as a nodular lesions, and they may be soft to palpation because of the extensive cystic spaces present. And when such lymphangioma is occurring in oral cavity, in the tongue specifically, the tongue is enlarged because of deposition of excessive lymph tissue in the tongue. Macroglossia is seen, and the surface of the dorsal surface of the tongue, it just becomes irregular, and there are deposition of nodular lesions on the tongue. The dorsal surface becomes irregular, and grey and pink projections may be seen on the surface of tongue. And when such lymph depositions occurring on the lip, the term macrochilia is used. Okay. Clinical appearance is one of a nodular lesion, and it is just very similar in to other lesions. So when you go for a histological diagnosis, you see the characteristic proliferation of the lymph vessel there. So multiple intertwining lymph vessels may be seen in a fibrous stroma, the connective tissue surface. Epithelium is present in the epithelium, and in the connective tissue you get to see the characteristic proliferation of the lymph vessels. So numerous dilated lymph vessels may be seen, which are just lined by a single layer of endothelial cells. The single layer of the endothelial cells, whatever are lining the lymph vessels, they have a flattened nuclei with a plump appearance. Okay. Sometimes these lymphangiomas or the lymph vessels, they may be filled with blood. They may show blood-filled spaces. Then the term hemangiolympangioma is used. Okay. And there are different types of lymphangioma, basically histologic classification. Okay, when the term lymphangioma simplex is used when the epithelium is present and the connective tissue shows small thin walled lymph vessels or lymphatic channels. Cavernous hemangioma is used when the lymph vessels are little bit dilated and they are surrounded by this adventitia, that is the outermost lining of the capillaries. Okay. The term cystic lymphangioma is used when the lymphangioma is typically occurring in the lateral neck region where large macrocystic spaces are seen with the presence of the fibrovascular tissues. Okay. Benign lymphangioma is used when the lymphatic vessels are just interspersed with dense collagen bundles. Okay, and hemangioendothelioma is used when the lymphatic vessels are just filled with blood. Treatment for any lymphangioma is just surgical excision of the tumor is carried out. Now coming to the benign tumors of nerve tissue origin. If we see the nerve tissue origin, wherever it shows the benign proliferation, the commonest benign tumor is the neurofibroma. It is also known by other names, that is the von Reckling-Gausson's disease of skin. Basically, there is characteristic similarity between this von Reckling-Gausson's disease of skin and the oral neurofibromas in the characteristic appearance of the color. That is the CAF-A lot spots are seen. There is the pigmented macular spots. So that is the characteristic appearance of neurofibromatosis disease on the skin. Even the oral lesions, they appear to be a flat, pale or macular lesions. Okay, let us see how the neurofibroma. It is basically an inherited disease. It is transmitted as an autosomal dominant trait. It is a benign tumor of nerve tissue origin. Neurofibroma, essentially it may be seen as a solitary lesion or it may be seen as a generalized body part, as we have discussed. Neurofibromatosis, basically it is a very severe inherited disease, autosomal dominantly inherited disease. It is characterized by clinically by appearance of cafe-loid spots in the skin, and multiple neuromas or neurofibromas may be seen anywhere on the body or even in the oral cavity. So cafe-loid spots are nothing but pigmented macular spots. They show increased pigmentation. So we'll see how the oral neurofibromas appear. Oral lesions are nothing but they are nodular lesions which may be solitary, which may be discrete. They just appear to be nodular in region and they are situated on the buccal mucosa, palate, maybe on the alveolar ridge, tongue or the vestibule. And clinical appearance of, you can see in the clinical picture there is a neurofibromatosis appearing. Okay. Neurofibromatosis, the CAF-A spot, the pigmented milk-like spots as they are called. They are brown in color, deep brown to dark brown in color. Even the skin of back, it is showing the multiple neurofibromas, that is the CAF-A spots. Multiple small nodular lesions may be seen on the skin. That is the characteristic appearance of this disease. Basically, this disease, it involves the nerve tissue, right? The tumor cells, they just proliferate around the nerve tissue bundle in the axoplasm or the squamous sheath surrounding the nerve cell, and it just tends to proliferate along that region, okay, around the nerve cell axon. So the clinical picture is one of the appearance of cafe-loid spot in the oral cavity. Specifically, nodular lesions may be seen which are just non-ulcerated and sessile, and occurrence of macroglossia is characteristic. Along with that, sometimes there is because this tumor is involving the nerves, especially it tends to spread along the nerves because it involves the peripheral sheath of the nerves. Even when it involving the mandibular canal, and when you take a radiograph picture, you see that there is fusiform enlargement of the mandibular canal is seen. Which mandibular canal is the one which encloses the inferior alveolar nerve, right? So when the tumor is spreading along that nerve, the canal where the nerve is situated, that also shows little bit enlargement. And if this tumor is spreading along the trigeminal nerve, it may cause characteristic facial pain, paresthesia, numbness, and along with that, sometimes in few cases paralysis has been reported. Whenever the tumor is usually painless, it is a benign one, it is painless, and whenever it is putting pressure on the nerves, only then you see the clinical symptoms of associated with that particular nerve. So when you see the microscopic picture of neurofibroma, you see that there are proliferation of spindle cells which are having thin wavy nuclei, which are just intermingled with the other neural cells, neurites. And increased deposition of melanocytes is seen, giving the characteristic pigmentation in this. And there is sometimes a variant of neurofibroma known as a plexiform neurofibroma. It shows the characteristic, just the difference in the arrangement of the spindle cells. Okay, the peripheral nerve tissue is still scattered with the appearance of a collagenous matrix along with the presence of neurites. Treatment for any neurofibroma or nodular growth anywhere, either in the oral cavity or on the skin, it has to be just surgically excised. And there are, because it is a genetic defect, because of some mutation in the nerves, there are two genes like neurofibromatosis type 1 gene, type 2 gene. So because of the genetic effect in that genes, it is causing the disease. So this disease, once you have surgically excised also, it tends to recur. Though benign, the only problem it is causing is the pressure on the nerves, leading to the paresthesia of that particular region or paralysis at a later stage maybe. Okay, though benign, the neurofibroma has severe problems with the cosmetic region. What happens is, whenever the nodular lesions are occurring in the skin of back of hands, extremities and all, it presents a significant disfigurement for the patient. Okay, so for that region only treatment such as surgery is carried out for that. So Neurilemmoma is also another benign tumor of nerve tissue origin. It is also known by other names such as schwannoma. As with the neurofibroma, it is also a very slow growing lesion. It is a benign lesion, and the growth may be of very long duration. The Neurilemmoma, it may arise at any age. There is no gender predilection. Both males and females are affected equally. As with neurofibroma, they generally present as a painless nodular masses. They cause pressure only when they are impinging on the nerves. Painless nodular masses are seen here. Again, when Neurillemmomas involve the mandible, only when there is some lesion involving the bone, okay, and it is involving the nerve too. Considerable destruction of cortical plates occur, buccal and lingual cortical plates occur. Then there is enlargement or expansion of the alveolar bone. Associated with that, you can see pain and paresthesia. If the lesion of Neurilemmoma, it is occurring in the soft tissue involving the alveolar mucosa or buccal mucosa, it occurs as a nodular lesion, just like that. And histological diagnosis is important to characterize it as a schwannoma. Basically, this nerve cells or nerve sheath cells, they are basically composed of two types of tissue. There is Antony type A tissue and the Antony type B tissue. We'll see what is that. Antony type A tissue. Here, Antony type A tissue. Here what happens is, the cells with elongated or spindle shaped nuclei, they form a characteristic palisading pattern. Okay, and the intercellular fibrils, whatever are present, they are arranged in walls. The characteristic spindle shaped cells are seen, which are arranged in palisading pattern, and the intercellular fibers, they are arranged in walls like fashion. Whereas the Antony type B tissue, there is no such organization of the spindle shaped cells or the intercellular fibers. They just tend to be disorderly organized. And the appearance of microcysts or verrucate bodies, which are nothing but neurite cells, is seen. The tumor is encapsulated one because it involves just the squam cells or the squam sheath. So it is just encapsulated one. The tumor requires surgical excision. The chondroma is another benign tumor of mature cartilage. Okay, it is a benign neoplasm. It is involving the mature cartilage. Basically, the chondroma is seen in generalized body, in the skeleton of the long bones, the femur, the tibia. Wherever there is deposition of secondary cartilage or wherever the cartilaginous tissue occur, mature cartilaginous tissue occur, there you can expect a chondroma. Usually the maxilla and mandible, they do not have any cartilage in the adults, and there has been cases of, we see that during development of maxilla, secondary cartilage or cartilaginous deposition may be seen along the malar process, and during the development of mandible also we see that some remnants of cartilaginous tissue may be present in the condylar or the coronoid process. So these regions may harbor the cartilage tissue, so that they are more prone to develop this benign neoplasm of cartilaginous tissue, that is the chondroma. So we'll study the chondroma of oral cavity. Specifically, they develop at any age. They present clinically as swelling of the jaw, which are painless, which are slow growing, and the overlying mucosa just shows a swelling. It is not ulcerated. No features of inflammation are present. And when it is involving the maxilla, it is involving the anterior maxilla, and when it is involving the mandible, it may involve the body of mandible, the angle of mandible, or the coronoid and the condylar processes of the mandible. So radiographically, it presents a feature of a irregular, radiolucent or mixed radiolucent, radiopaque, mottled appearance of the bone. Okay, when you see microscopic picture of this particular mottled lesion, mottled appearance, whenever you see radiographically mottled appearance, when you send that swelling, that particular swelling for histologic diagnosis, you see that a mature mass of hyaline cartilage is seen. Along with that, few areas of calcification may be seen. The cartilaginous cells, they just appear as small round uniform cells with a single nuclei, as seen in the mature cartilage tissue. But the lesion shows few areas of calcification or osteoid deposition. A treatment for this is nothing but surgical. Chondroma is relatively rare in oral cavity because of the scarcity of cartilaginous tissue here. The chondromas are more common in long bones of skeleton, wherever you see the mature cartilaginous tissue in the metaphyseal and the epiphyseal plates, femur, tibia and all. Now we'll see osteoma. Osteoma is another benign neoplasm of oral cavity, the connective tissue origin. It is basically a neoplasm characterized by a proliferation of either the compact bone or the cancellous bone. Osteoid deposition basically occurs at any site, giving rise to this characteristic osteoma. The osteoma, they may occur in oral cavity at any place, as the maxilla, mandible or jaws. Osteoma may be seen in the long bones of the skeleton also, in the femur, tibia, in the ribs. Anywhere you can see this osteoma deposition. Whenever it is occurring in jaws, we'll see the characteristic features of jaw. They may occur at any age, and clinically they just present as a circumscribed swelling of the jaw. Due to the swelling, it produces characteristic facial asymmetry, and the tumor is very slow growing. Radiographically, the osteoma or the osteoid deposition is seen as well circumscribed radio-opaque mass of tissue in the region of swelling. Okay, when you send the swelling after excision, if you just send it for histological diagnosis, when you see the microscopic picture, you see that there are deposition of compact bone. There is deposition of extremely dense compact or coarse cancellous bone, and the surrounding adjacent normal soft tissue is seen with the epithelium and the connective tissue, but just it shows the deposition of osteoid. So that's the feature of a osteoma, or a benign tumor of connective tissue origin, which is characterized by deposition of osteoid. So there are other common neoplasm of osteoid tissue, that is the osteoid osteoma. It is a benign tumor of bone. Basically, it is occurring in young persons, and when seen histologically, it is also characterized similarly by the deposition of either the compact bone or the cancellous bone. Clinically, again, it presents as a localized swelling of the soft tissue, but the osteoid osteoma is characteristically different from osteoma in the appearance of pain, and this pain is severely excruciating, and it just gets worse at night. Okay, characteristic feature of pain associated with swelling, and the pain, it just gets worsened at night. And osteoid osteoma cases were more commonly reported in the long bones, that is the femur and in the tibia. Even in oral cavity, mandibular region shows the appearance of this osteoid osteoma. Clinically, radiographically, they just present as round or ovoid radiolucent area, which is surrounded by a thin rim of sclerotic bone. When you see the microscopic picture, then you see it is composed of dense, compact osteoid tissue. The osteoid tissue, it is just bordered by the active osteoblasts. These osteoblasts are responsible for deposition of osteoid. Along with that, at few sites you see osteoclasts are activated. Presence of osteoclasts, large multinucleated cells are present. Osteoclasts represent the foci of bone resorption, and the periosteum of the bone, it shows it is bordered by osteoblasts, showing the osteoid deposition. Okay, new bone formation is seen along the periosteum. Treatment for this is nothing but the surgical removal of the lesion, soft tissue lesion, which is manifested as a swelling, is just surgically excised. So that's the histologic appearance of that osteoid osteoma. The whatever the hyaline stain, eosinophilic stain, light pinkish color stain, that is nothing but the osteoid tissue being deposited. Benign osteoblastoma, it is different from osteoid osteoma. It's also known as a gained osteoid osteoma. It is more commonly seen in young persons, and there is predilection for occurrence in male. It is also associated with pain as in case of osteoid osteoma. The only difference between the benign osteoblastoma and the osteoid osteoma is the occurrence radiographically and histologically. Radiographically, this benign osteoma or gained osteoid osteoma, it shows the occurrence of a mixed radioopaque radiolucent appearance, okay, because of excessive deposition of osteoid. And more commonly, this osteoblastoma cases were reported in long bones. There is a vertebral column, sacrum, calvarium also, even the skull was affected. So when you see the microscopic picture, along with the characteristic deposition of osteoid, there were increased number of capillaries seen, increased number of multinucleated gained cells. So osteoblasts were more in number. They were actively proliferating, so contributing to the excessive deposition of bone along the periosteum, and this contributes to the mixed radiolucent radiopaque lesion or appearance as seen in the radiograph. And few of the authors, they just told that the gained benign osteoblastoma, it was actually a gained osteoid osteoma. It was actually a form of osteoid osteoma only, but with more presence of osteoblast. Because of the excessive proliferation of osteoblasts, it was giving an appearance of an osteosarcoma, or it was giving an appearance that it may transform into a malignant lesion. So that's why this benign osteoblastoma was considered separately and grouped separately as a gained osteoid osteoma. There have been cases where malignant transformation is occurring in few of the cases. Torus palatinus is nothing but a well-developed bony excrusions seen in the palatal region. Torus palatinus, as the name indicates, is a bone formed in the palatal region. Most commonly, this kind of torus is seen in the midline of the hard palate, and the women are affected more frequently than men. The occurrence of torus may be noticed at any age. It may be present from birth also, and it appears as an outgrowth in the midline of the palate, as you can see in the clinical picture there. Okay, it is just appearing as an outgrowth in the midline of the palate, and based on the characteristic appearance of the torus, it is just classified as a flat torus palatinus, spindle shaped, nodular or lobular torus palatinus. The overlying mucosa of the torus, it is just intact. It does not show any features of inflammation or ulceration. The only problem with torus palatinus may be the construction of dentures, or when it is being repeatedly traumatized and it is causing considerable problem to the patient, only then it is considered for surgical excision. And the few of the times torus is just torus is just considered while construction of dentures also, but it becomes a site of trauma after construction of denture. For that cases, it is just surgically excised. When you see the microscopic picture, radiographic picture, it just appears as a radio opaque area in the central region of bone. And when you see the microscopic picture, the torus is composed of dense compact bone. Torus also occurs in the mandibular region. This exostosis or outgrowth of mandible, outgrowth of bone, it occurs on the lingual surface of mandible, which is seen above the region of mylohyoid line. And there are these torus mandibularis occurs bilaterally, so lesions may be seen on both sides of the midline, and this growth occurs above the mylohyoid line, that is just opposite the bicuspid teeth, premolar teeth. Treatment for this includes surgical excision because it causes considerable problems when constructing a denture for the patient.